the question in one go. Is that clear to all of you? Okay. So has they joined the international partners? Okay, okay. They say they can't hear us. AV team. Can you hear us now? Can they hear us now? Can you make sure they can hear us? Okay. Okay, let's continue. Let's hear the Indian experience, their journey. And soon our, oh, here they are. Okay, so you can start. Okay. Yeah.
Sure. So thank you so much, everyone. So I think the purpose of this actually is to be a little more interactive, so I won't speak very much. But the goal, I think, for us is to frame that there are many layers that might be part of a digital health blueprint that can actually unite many different approaches towards the same problem in a common blueprint. So maybe Anushree or Vijay, if one of you are able to share the layers of the proposed health blueprint, that might be a good start. But the first framing point is to say, let's identify all of the blocks that we need to put in place from a DPI standpoint, rather than from a digital health standpoint. From a digital health standpoint, you need many, many, many systems, right? And each market player will build their own. But it would be powerful to articulate what are the minimum blocks and what are the key characteristics of each of those. So for example, in this morning's session, we heard Elaine talk about interoperable data standards for healthcare. We heard about consented data sharing. We heard about a facility registry, essentially a registry that combines core information about all of the hospitals or different labs or pharmacies that you might have. We heard about a professionals registry, which is essentially, let's say, a registry of nurse practitioners or a registry of doctors, which is actually usually held by a bar or medical council in a country already. One important thing to frame is that when we say registry, we don't mean like a 2,000 data field consolidated, centralized system that knows everything about every health facility. The goal of each of these registries is to be quite minimal and to collect only the data that tends not to change much over time, because anything that's very dynamic, you'll have to keep going back to the facilities to actually say, can you update this information? So at a starting layer, I don't see if the slide is up yet. Maybe Anushree or Vijay, if you can share the health blueprint slide. The baseline layer that we frame is that of registries, because it is crucial to have your nouns in the ecosystem, whether it's a hospital, a lab, a doctor, or any other noun, to be identifiable, so that tomorrow if someone wants to build telemedicine, they can have the same registry of doctors that they can call on. And you don't have each new telemedicine app building its own registry of doctors and competing on the registry of doctors, right? So that's, as a core foundational layer, sort of crucial. Then we frame sort of at the top then above the registries, we try to frame other types of data or credentialing as a layer. So for example, the ability to publish a vaccine certificate, right? If any of you went to the UK or the US post the vaccination, you would be surprised because they had paper vaccination certificate slips that they were giving out as a result, right? So even advanced economies struggle with this problem. It's not just, emerging economies. But I think India and Bangladesh both took on this approach of saying we need to have machine-readable vaccination certificates with the foresight to say this is going to be important for everything from getting a job and applying for a job to being, if someone has to work at a hotel, they had to prove that they were vaccinated, right, in order to get that job. So that credential has to become an asset. So for that asset to kind of be put into place, you had to have certain standards. So you have to define to say, what are the main building blocks that you need? So for example, stay on this slide, Anushree. So I think, this baseline layer of identities and registries, this is something that we wanted to get your feedback on, articulates, what are the main blocks that we might need at a national level. So it would say the facilities registry, which was pointed out by Elaine as well, the professionals registry, which was pointed out by Samir from PATH in the morning. And you might also have a diseases registry, an organ registry, an insurers registry, so that anytime anyone wants to settle a claim for health insurance, they could actually reach out to that insurer. Or you might also have a drugs essentially registry so that you can verify and to see what kind of drug is being issued for a prescription, right? You can have a standard way to reference it in every prescription. So I think this row of identifiers and registries is sort of a first crucial building block, a set of building blocks that are important for the health ecosystem. On top of that, we frame a data layer of open data exchange and models. The way to differentiate these two, I think, is to say that the identifiers and registries is largely immutable data or data that doesn't change very often, right? So essentially, the information on your driver's license doesn't change every day, right? Mostly it's the same. It's your name, it's maybe your gender, which could change, but not frequently, your address and other things. So I think the goal is these are for the nouns, and then the top layer of data sharing is for much more dynamic and real-time data. Can you have mechanisms to actually share that data in real time? So let's say I go in and get a lab test done, or I go have a consultation. Am I able to share that data in a mechanism that's consented, trusted, and secure? That, for that we've framed sort of health data sharing APIs, as well as sort of a mechanism for consent as well. And there's also another part of the data layer which looks at sort of anonymized open data. So public data sets, let's say for tracking through a disease that has spread or any sort of aggregated, anonymized public data. It's important to publish this as well for a variety of research purposes. And then finally at the top, sort of the top blue layer, we frame sort of a layer for services and transactions. And the goal of this is kind of to make it clear that ultimately healthcare is a service, right? It's a service that you obtain. Either it's from a doctor as a consultation, or you get a surgery done, or you get some advice on your nutrition. All of this is a service economy. So how can we make it frictionless for you to discover the service at the right cost and price, right? And so for this, the open network for health services is sort of, if you think about it, it's like the layer that might ensure interoperability across telemedicine apps. So today, if you have one telemedicine app and it's able to get a group of doctors, it's able to go to one set of customers with one service, now are you going to rely on only that one telemedicine app to become the monopoly in the whole country that offers all of the services? Or would you rather have a few different options for telemedicine apps, but each of them don't have to recreate their own supply side base and their own demand side? So you have a network essentially of telemedicine apps, and what could power that is sort of a common protocol that describes the health service. So this is a key sort of building block that we think is quite important. There's also sort of a health claims settlement, sort of a protocol for settlement of claims. I think, as Anushree was mentioning in the morning panel, one of the key things that we have to solve is actually the cost of processing a claim. Because the reason that somebody pays out of pocket instead of pays through their insurer is because the provider doesn't want to accept the insurance because they get paid very, very late, or they don't know if they will get paid. So they prefer to take cash directly out of.
Those need to be on the impact line, not an output line. Like I have implemented an AI, or I have implemented a registry, so I'm done. But what that as a registry supposed to deliver, are we delivering that?
Yeah.
I think in Bangladesh blueprint, those definitions, those articulations needs to be there on top of the digital model.
No, I fully agree with that framing. In fact, most of what we were having a conversation earlier, that in the hallway, that the devil of these blocks is in the detail of how you choose to execute it. And the metric, I would push to say that the metric of success is not the development of it by itself. Like to say, okay, you have a registry that has maybe 4,000 hospitals in it, right? The metric of success is how many other institutions are using the registry regularly. That's the metric for this, for example, right? So is there how many telemedicine apps, how many hospital apps, how many other entities trying to solve for healthcare are transacting? And therefore, if you have 5,000, let's say, hospitals in your facility registry, the metric for how many times that will get used will go into the millions. So it's actually much higher, a much higher ambition to aim for usage. And it's actually simpler because you often have to do less, right? To collect less, but to make sure whatever you do collect is trustworthy information. Even if it's not sufficient, it's a good start. And I love this framing of saying, look, we have to frame how other entities are actually benefiting from the digital infrastructure that you've put into place. And that's the main metric. So even for data sharing, right, should the focus be on the number of people, or should the focus be on the number of, let's say, transactions, right, that you've done, or should it be on the number of people that have actually closed an insurance application with data sharing? So data sharing in and of itself is not a good in that sense. You're trying to aim for somebody to get better care or to get better insurance or to get a better use case. So I think clearly defining the outcomes is a great suggestion. But it would be great to hear from folks in the room. I think there were a lot of hands before lunch. So to get thoughts on what's missing and how do we articulate this better.
Hello, I'm Fahim Hussain. I'm working as a senior consultant at DGHS and working with the Shared Health System record team. Yeah. Basically, my work is based on the networking aspect of the whole thing in terms of the scaling the microservices, whichever we have. Since the end game is actually to supply softwares, the APIs to a lot of large amount of people. So scaling is very important as well, right? In that context, what kind of security challenges? Because data breaches are very common in the whole ground. When you scale software of this magnitude, we are also looking into different aspects of security, which is important for the confidentiality of the patients and everything. What are the measures that can be taken, as well as is there any standards like SOC 2, or what are the standards? We need to also come to a point where we can settle to a security standard. So is there something that has been used in India or any other else that you might know of?
Yeah, please.
So actually securing the whole system as a whole is one concern. And when we are again bringing in the topic of DPI, which have to have that openness and availability first. So there is a dilemma in a balance sheet over there, that what to secure, what to not, what to be more available. Like if I am securing those facility APIs, very tight, and which have to be authenticated again and again, there are some aspects as well. So is there any best practices or proven cases over there?
Yeah, I think the security question is a very important one. And I'll ask Vijay as well in a minute if he can come in on this, since he's thought through this carefully. But I think first the goal is to build something that people don't want to hack. And this is a bit counterintuitive, right? So when you start by saying registries, right? the temptation is to say we'll build one central registry for all of the information. Put doctors in it also, health workers also, facilities also, and it's the unified health registry, right? It's very tempting because you're like, okay, it's simple, it's just one thing, everyone will have to put into that one database and it'll be a honeypot. But we always recommend against this because it creates a honeypot for any kind of hacking or cyber attacks. So the first step is to kind of opt for an architecture that's federated so that any one point is not a huge vulnerability. Even if you have facility registries, let's say, you can federate it by province, right? So that each province has their own and you don't have to always have just one facility registry. You can have a network as long as they're all sort of as per similar data schemas and they can be pinged using the same APIs. You don't increase the complexity, but you increase the security. So one aspect of this is to kind of federate where possible. The second, of course, is to focus on again, minimalism, right? And not overload the database with a lot of information that is very sensitive, right? Just stick to what's absolutely required and not go abroad. Of course, above and beyond that, there are a number of security best practices, on encryption, on the way that you set up your data systems and structures, which you can do a whole another course on. But I think those, to the extent possible, those should also, of course, be adhered to anytime you're handling sensitive information. But I don't know, Vijay, if you want to come in on the security point at all.
No, Kam, I think you covered both the key points, which is the minimalism is the key, which is, from a DPI perspective, it is all about the strategy of what is the purpose of those registries and trying to keep them minimal. So the need for hack is avoided, point number one. Point number two, whatever is already public, that's the whole point of digital public infrastructure. We used to have this whole concept of yellow pages, right? And now we are kind of making it digital and bring the trust angle to this whole transaction. So I would only like to add one more thing to what Kame already said, is to the whole idea of these registries is to bring that trust for enabling transactions without losing any secure privacy, enabling information being compromised. That's the key principle. And the whole infrastructure database, that goes as a commodity, and I don't think we want to talk about that in detail, but there are enough best practices, training modules, and companies, consultants, and agencies who will enable those things. One last point I would like to add is that that's exactly one of the reasons when we took Bangladesh Health Blueprint, or the one that Kamya talked about. The idea of pseudo IDs and not to try to tag everything to foundational ID, especially in health space, to bring that privacy angle also balanced out, becomes crucial, so that it's a one-time onboarding wherever there is that requirement to do a deduplicated ID binding has to happen. After that, everything has to happen in the functional domain, so that that high correlation across sectors, databases, systems can be, we can try to avoid if possible. That's the last point I would like to add there.
I just want to add, because my 15, 20 years experience with government system and especially with the health is this is a continuous process. Like, I'm hearing this question last 10, 15 years. And it has to be built into your hygiene, into your practices, into everything. It's not like you do it, you make it 100% secure today, it's not going to stay secure tomorrow. So DGHS and DGFP needs to revamp their work processes, and they have to stick to some standards. That is absolute key.
Agree. Thank you. Any other questions?
Yeah. I have one. I am Faiz Ahmed, working with DG Health on behalf of Bloomberg Philanthropies. Actually, we are talking about DPI and AI. Actually, whatever we are doing for the citizen, goods of citizens. My question is actually, is universal health coverage important to identify the citizens' need to implement DPIs and AI? And are we ready? So for AI implementation, we need data sharing process. But as we know, in Bangladesh, interministerial data sharing is too much challenging. And in my point of view, it should be controlled by one unit so that everyone can get the data and share with each other. So the question actually I am also looking for about the universal health cover is important or not. And one thing in panel discussion we have figured out that unique health ID. So are we talking about only unique health ID or unique ID for a citizen? As a citizen, I'm not willing to carry so many identifications. I like to carry only one. As my name is Faiz Ahmed, so my whole life, born to death, I will carry the name. So can we think about this? So we can carry only one number so that if anyone asks me, I can deliver it to him. So I don't need to remember anything else. So these two questions actually from my side.
Super. I'll take the first one on health coverage. Maybe Vijay can come in on the unique health ID. I think it's undoubtedly true that we do need universal health coverage of insurance. Now, so because not many of us, when a health shock hits, will not be able to pay for it out of pocket. And there are institutional mechanisms to solve for this problem by dispersing risk. That was the whole point of insurance. And so these should be accessible to equally to all people. The question I think you're asking, which is more nuanced though, which is it the state's responsibility to ensure unique health insurance coverage, and should the state be paying for that, right? And I think that is a sort of a very country-by-country assessment and question. I think in some countries they have made it the state's prerogative and they've covered everyone under state health insurance. In other places there is sort of private insurance coverage, and you get to universal by a combination of private players covering most people. I think, though, that whether sometimes this question of is it the state that should pay for it or the private folks that should pay for it is actually a bit of a distraction. Because no matter what, somebody is paying for it, okay? And the problem we actually are trying to solve is how can we make that coverage effective regardless of who's paying for it? Right? So if it's a private player that's like insuring everyone, or a combination of private players, they too have costs, they have risks, and they have to actually engage, in the same digital health ecosystem, right? Even if it's a public health provision of the insurance coverage, they might have to engage with a private player that's given the health facility, right? And pay for that. So the question of is it a public or a private insurance, I think is a bit of a distraction. Regardless of whether it's a public paid insurance or whether it's a combination of private players, they'll still need rails. And those rails are what we're talking about today. They'll need the rails to share information. They'll need rails to ensure that they're able to settle a claim in real time. And they'll need rails to be able to monitor, audit, have trust across the ecosystem. And I think regardless of who's paying, these rails are what we're here to talk about. To say how would you characterize those rails? What are the main characteristics of the ones that succeed versus the ones that don't scale up? I think that's the sort of key point on this. But maybe if you want to come in on the health ID point, maybe Vijay, or you can come in on that.
Vijay, you want to cover the ID part?
Yeah, sure. I can take a shot. And it goes back to the previous point on security as well, right? And the question that is being asked is, should I have one foundational ID and use it for all purposes? I'd like to just get a quick poll from the room here. How many of all you have more than one email address today? Can I get a show of raise of hands?
Yeah.
Yeah, there goes my answer. So if this is outside the business, primary business email address that we all operate in, we do have multiple email addresses today for segregating certain aspects of our life and managing our communications and information in a personal domain. So if that is the case, and what are the reasons why we have that, let's reflect on that. It's also to balance that privacy and security aspects of what we operate in, right? When it comes to health, the answer lies there actually. So, and especially for the global south countries where the evolution of socioeconomic parameters are also growing up, in health, becomes super important to segregate the systems and records when if I'm taking some mental health prescriptions and help from those departments and ministry aspects of the health versus a general health versus a cardio health and so forth. It becomes important to give that choice to the end user so that it is not mixed and matched into one big bucket and then later on it creates a kind of an scenario where it becomes hard to manage those records, and especially when it comes to privacy of that individual. So purely from that aspect, our belief is that the underlying architecture should definitely support multiple IDs and ideally pseudo IDs if possible in healthcare, and decouple it from the foundational ID. And nothing stops if that architecture is consumed and built out. Nothing stops. It's just a policy designed to make one single universal ID in due course of time. Rather than creating one ID and trying to do the other way around, you'll have to go and re-architect the whole system again for the next decade. So with those two key points, I'll just rest my case that having multiple IDs and giving that choice to the end user is something, a good thing to think about and move forward with that.
Yeah, and I think just to add to that, when we say having multiple IDs, we don't mean that the government has to then, the Ministry of Health has to go recollect all the information that the national ID has covered for 99% of the population. We're not saying that. We're saying that you should have an addressable, a health address in some sense, a personal health address. So that, and that can take, it can use an eKYC from the NID to populate the first 4 or 5 fields. But the main point of that is to create, in some sense, like something that's like Mohammed at NIH, whatever. That's like your health address. And then you can go to any health institution and share that, and that becomes your way of fetching your health record if you need it in the future. I think that's one way of framing it, as so that it builds on the layers. Let's say if you already have a foundational ID, it shouldn't try to recreate the foundational ID, but it provides a mechanism for the individual to aggregate health information that's separate from, let's say, what they'd like to do with their foundational ID or with their driver's license or with other kinds of IDs. I think that's kind of how we're thinking about it.
And also in the context of Bangladesh, health serves the population, not only the citizen. So yeah, there are a lot of spaces where the foundational ID, you cannot use the NID. So health has to address that as well. So that needs to be understood as well.
That's a good question. Any other questions?
Hello, this is MD Aminul Islam, Assistant Professor, Department of Health Informatics, Bangladesh University of Health Sciences. I have been working in digital health last 13 years. So I have 3 questions. First question is, as a country perspective, if we consider India and Bangladesh, from top level view, since we are now working on digital health enterprise architecture blueprint in our country, now working is going on. So how you differentiate 2 country perspective? What should we think about if we think digital blueprint? What will be the difference architecturally? Second question is, last session we are talking about that DPI is very important. It's the core component of the architecture blueprint. But how about the sustainability of the DPI? Because you need continuous budgeting, the manpower to, capacity. How do you manage in India? Can we get lesson learned from that things? And do you have any initiatives for sustainability or any mechanism? And my third question is trust. Nobody talk about the trust, because when citizen move from manual system to digital systems, the bottleneck is, the challenge is that trust. They don't want to, so they think that the system will not work. Maybe they lost their data or so many things they come up their mind. So in India, how we learn from India the trust build up things? Thank you.
No, good questions. I think to the first question to the second question actually around sustainability, this goes back a bit to the point that, Anushri made in the previous session on the panel, which is that in order for something to be sustainable by itself, every player in that ecosystem has to have a strong value proposition to engage in it. right? So maybe a hospital wants to engage in a data sharing ecosystem. Maybe to kick it off, the government pays out some incentive or some subsidy or some tax break to bring people live onto the data sharing ecosystem. But in the longer term, for the hospital, what matters is, can I use that to reduce my costs somewhere? Can I use it to build a practice in an adjacent area to grow my business as a hospital in some sense? So I think the core question for sustainability is the same question as the one for adoption, which is, how do I make sure that there is value in adopting each of the blocks for all of the players, right? And that it's designed in a way that is minimalist so that the public spend is as low as possible. And fortunately, the DPI approach versus a regular digitization approach, the DPI approach tends to cost less over time for a government, because its framing is, can I have the government do slightly less than it was assuming it could do and simply lay the rail for many private players to succeed and spend their own budget to do it, rather than only relying on the government to actually execute end-to-end and have all of the hospitals in their network and publicly financed, right? So I think because of the bias, see, healthcare is expensive. You can cut it anyway. It has a cost. But it's rather than expensive, we say it's costly. Because expensive means it doesn't justify the cost. I think it's one of those cases where there is a cost, but there's high value for spending on healthcare. Now the question is, can you spend as little as possible in order to maximize bang for buck in that sense? And that, I think, is what the DPI approach tries to promise compared to regular digitization, where you build the whole solution yourself. Like, you not only put out a set of APIs for telemedicine apps, but you build the whole app and you put it on the cloud. You pay for its development, its running, and all of it. So rather than building the end solution for all of the services, I think we're trying to articulate that if you can build less, and that's actually more sustainable, and the market players invest in the end solution because they see a value proposition, right, for doing it. So that's how I would frame the sustainability question. You had another question about trust. Yeah, I don't know, Vijay, you want to take a stab at that, or maybe Vijay, if you want to come in on how to build trust. I can also speak, but after you. Yeah.
Sure. So trust comes at multiple layers, right? One is at the transaction layer, like the layers that Kamya talked about, the blueprint. And just like security, that goes across layers, starting from underlying database, how information is handled, and how information is architected and used in the larger solution. Likewise, trust has to be looked in that context. And from DPI approach, what we look from trust is that I think this would have been talked in the previous sessions as well, is we try to identify that small +1 capability into this whole data handling and how we handle information, so that that information, when it is flown from digital realm to physical realm and vice versa, trust is not lost. The quality of the data and who has authorized to share the data is not lost. And one simple example that we've been using very aggressively last many months is the QR code, digitally signed QR codes, and the verifiable credentials that gets issued across all these registry layers. What we say at this point in time from DPI thinking is that it should also be having a PDF equivalent format of that data represented, and the PDF should carry a QR code which is digitally signed, like we are used to the payment world, digital payment world. And so those kind of learnings is what one has to take from the payments world, where many of those same set of users who are not digitally savvy, digitally literate, are able to use those payment transactions, mobile transfers. Can we bring those learnings into the realm of healthcare and transactions? So that's one simple use case that we're looking at. And the trust goes across beyond that, as simple as that. And we have to unbundle these layers and then go deep dive, I would say, at this point in time. Kam, if you want to add anything else.
Yeah, so I think we heard this morning about digital signatures and electronic signatures, right? What's the difference and how do we think about it? I think digital signature is one extremely powerful strategy to build trust, right? Because what it does is it's a technique that tells you that this has not been tampered with since it's been issued, right? So if a digital signature is voided, I mean, it means that someone has tried to mess with it. But the powerful thing about introducing digitally signed QR codes versus any QR code is that you know that the stuff in this QR code has not been tampered by anyone in the middle. That's not the person whose logo or institution is at the top of the credential. So that's one very powerful technique to introduce trust. Then I think there's a layer of sort of institutional trust that gets built when you say, okay, if something is an A2I, like you see all those 4 logos at the top of this conference, those institutions all inspire a certain degree of trust, right, on the level of rigor, on the public interest. And so I think there is oftentimes, that's why when you see ecosystems, if you go to a new country and you get a new, to Vijay's example about payment system, you get a new debit card, it has the little, you don't know the name of the bank, but it's got the same size and shape as most debit cards you use, and it's got the logo of, let's say, Visa, MasterCard, one of these two. There's 2 layers of trust that you've established. One is it looks and feels the same as your debit card in your country. So it's actually trust on the standards that you've grown up with. And the second is the institution or the brand or the set of networks. So I think both layers will have to be determined. We have to frame trust at a digital layer in terms of, are we doing everything we can to ensure traceability, auditability, and non-tamperability. And then there's a trust at an institutional layer of who interacts with the citizen and can I trust that institution. I think both layers are important. Yeah.
Sure.
Last question is not answered.
Oh, sorry.
Digital health architecture blueprint, the
difference between. Yeah, so this is a very interesting question of how do we look at this across countries and within a country, right? If you ask folks in India, they'll tell you India is made of 28 different countries, right? Each of them have different cultures, traditions, and setup. But the question I would ask is, we are a global economy now. It's 200, let's say 190 countries. Do we each have our own internet? We don't, right? There are some networks on which we agree that the infrastructure is remarkably similar, right? Similarly, you have sort of standards for payments, let's say, that come out. And we don't each have our own standards for debit cards. Our debit cards are all roughly the same shape and size, right? That said, the banks are different in every country, and the way they interact with people are different, the branches are different, the cultures are different. But globally, everyone agrees you have to do a KYC. Because they say, look, you need to actually know your customer, it's global anti-terrorist regulation, etc. So I think that there are, at a core level, very human characteristics and needs that end up creating infrastructure or standards that are truly global, which don't need to be reformulated. I mean, in some sense, a payment is a payment, whether it's made from a merchant to a person or a person to a government or a government to a government, in some sense, regardless of which country it's in, right? Money flow is money flow, and the systems that you build to respond to that, to some extent, will be the baseline protocols might be constant. Now, I think everything except that ends up having to be tailored to a country context, especially when you look at the blueprint, as we talked about. The key thing is not even just identifying the blocks, because these blocks, I think, will be relatively constant across countries as needs. But the question is, what is the use case and the value proposition and the order in which you build these blocks? That will vary tremendously from country to country, right? So let's say, for example, if you look at just the original sort of DPI that's not even health specific but health agnostic, let's say identity, payments, and data sharing, right? So India started by building first identity, then payments, then financial data sharing. Brazil started by building payments, then data sharing. Now they're coming back to identity. And let's say someone like Thailand has built identity and payments and not yet touched data sharing. So the order, especially, in which you architect will be based on what is the current political need, right? And what is the most felt need of a population. And the use cases that you use to drive adoption of your data sharing might be different. In Bangladesh, we saw the chart that maternal health might be a core use case or area that you use to drive. In other places, it might be elderly healthcare, or it might be, in West Africa, it might be Ebola care, right? Like response to a pandemic. So I think that way, thinking through while the core blocks or the way that you share data, it's not going to be that different, right? Maybe some of the elements inside your health data dictionary might be different, but the fact that you need one is not likely to be different. You have insurers in every country. They need to settle money between them and hospitals. The insurance claims protocol is not going to be different. But what will be different is how you choose to govern and regulate these infrastructures, and how you choose to roll them out, with which use cases or priorities.
Okay. In terms of Bangladesh blueprint, I think a lot of us want to see not only the technology stack, but since you said it's enterprise architecture and all, I think you want to see more of a transformation journey. So we should incorporate how we actually implement this, right? So you are like more looking at the mindsets, behavior, and cultural change that is required within the government providers, let's say DGHS and DGFP, because you see the technology was moving faster than the government decision making. Now it's moving even faster than the government decision making. So how do you bring that agility within the government so the implementation is still risk-free? Because it's, at the end of the day, it's public money. So yeah, I think the Bangladesh blueprint, not only, yes, we need an enterprise architecture for that, because we already have 30+ systems, only in the DGHS. So how we bring all those things into one picture, and then the DPI kicks in. So yeah, that comprehensive blueprint needs to be there. And also the journey. So who are the leaders? What competencies they require to transform government itself? And what kind of mindset? Because you said the consent. You talked about, for example, forget about digital. We have had experience where we saw forms, government forms, with citizens' NID printed on it is lying on the road. So yeah, that happens. So that's also a big problem for us. So yes, a lot of our practices, a lot of our mindsets, and a lot of the things we do culturally that needs to be transformed along with the DPI itself. And that, I think that should be also part of the blueprint, not only the digital stacks or how systems will work. So how the entire organization will transform one state to another, that needs to be addressed in the blueprint. And about the sustainability, I think the DPI approach will be much better, because one thing is, as I said, the technology is moving faster than the government decision-making process. So when you will have the private organization is working with the DPIs, they will move faster. But then again, the government needs to be a bit more agile than where they are now to accommodate them. They should not feel threatened when the private sector kicks in with their disruptive ideas. And another thing I should say is the blueprint should also address a couple of the very fundamental practices that actually stopping government from drastic transformation. One is how they bring consistency, for example, in the decision, so that decision will be carried forward from one officer to the another, and also flexibility, how they bring in flexibility in the decision-making process, how they bring in agility in the decision-making process, and then also continuous improvement. Government don't fail, they just forget about it. So if they don't fail, they don't learn. So if they fail, how they will recognize and improve, and they update their protocol, they update their standards, they update their work process. So if we struggle to bring those change in, then we will fail in a lot of these efforts, and a lot of the initiatives will not actually work in a longer run. Thank you.
I think we have time for one last question. And okay, raising your hand higher than the others. So please go ahead. Yeah.
Waiting from the first session. So I think it's may not be directly connected to the DPI, but as we have already discussed about the consent mechanism. So my question was, in a context like Bangladesh, where we have unreachable data owners, aka the citizens, so where they're not highly connected. So what could be a good example of establishing this consent mechanism in a country like Bangladesh, where we cannot actually reach the patient or the owner of the data at the moment when it is being shared? And the second question to Vijay would be, how does ID and consent complement each other? So how these two systems interact?
Vijay, why don't you go first?
Sure, Kamya. So, consent is just an enabler for a transaction. That's how we look at it. Identity is proving who you are, and consent is basically enabling the digital transaction. Just giving the identity and authentication doesn't mean that you are accepting the transaction that you are doing at that point of sale, right? Be it a digital transaction, be in healthcare or e-commerce and so on, so for education and so on and so forth. So to us, e-consent, when we bring e-consent into the mix, identity becomes a component within the consent to say that this person who is consenting is who he claims to be. And digital ID enables that seamless packaging of that information, so that the consent and who is giving the consent and for what purpose, all those components makes a consent. Identity alone is just an underlying foundational building block of just proving who you are, like national ID as an example, or any functional ID. And the other aspect of e-consent and digital consent that we talk about is that it's being designed in such a way that it's granular enough so that the digital systems, especially in the AI world, I don't think we answered one of the delegates' question earlier, the data sharing in the AI world, AI models. This consent will help enable that as well as an additional exhaust in the digital transaction as part of the consent. One can say, okay, give my anonymized data as an outcome of this transaction to this XYZ entity so that they can benefit in their research activity, as an example, right? So that's where the consent and identity are polar opposites to me, though it looks one and the same from a physical world to digital world when we look at it. But if you're looking truly in a digital realm and digital end-to-end transactions, making these systems which are interacting with each other much smarter, having a digital consent will make it a lot more super useful and productive for the systems to interoperate among themselves.
So I think, yeah, just to add to that, I think the way that you're thinking about consent also is that it can be batched or made granular depending on the current conditions. Okay, so the first framing is that there are ways to interact if the person is not online, as long as the person they're interacting with is online, right? So one solution is to say, I'll craft agents or assistants, right? That where you can reach a patient, let's say, in a way where the agent has the connectivity and the person doesn't have to have their own device. So one way to do that first is to publish sort of an open standard, in some sense, for consent and a set of APIs for it so that you can have diverse agents take off. And you don't always have to reach the customer on their own app or their own phone, right? So there can be voice-enabled consent, for example, that you can provide, as long as there's somebody on the other side that's able to translate it. Sorry?
Some sort of trust mechanism also?
Yes, and that's a licensing regulatory framework which you can craft to say these are the onboarded, let's say, partners, let's say, that are part of this ecosystem, and you go through one onboarding for them, and those partners then can enable. So creating a mechanism by which you can have diverse modes of accepting the consent, right, or communicating it, For example, I can share it by voice. I can just tick a box, or I can just scan a QR and say, okay. Or I can obviously go through on my smartphone and go through in an app. Or I can reply to a WhatsApp bot and reply with my consent. I think the first framing is that you should frame not just one way. If the only way you're giving consent is I scroll to the bottom and then I click I agree to give away my kidney somewhere in the middle, that's broken, right? So consent, it needs to be represented in a digital form, and it needs to be, but in the back end, and have many front-end interfaces that are crafting multiple modes of communicating that consent to a customer and then recollecting it. Then I think there are intelligent mechanisms to craft around repeatability. So for example, you can call for a recurring consent, right, in certain situations, or you can craft for a conditional consent, where you take it in advance when they have connectivity to say, in case of X, I can do Y, right, which in a health context is a useful phenomenon. Or you can do a delegation where they can delegate consent to their next of kin or somebody who has a connectivity area. So I think thinking about this as an architecture that enables many scenarios is probably the right way out, because some folks will have connectivity, some will not, but they will always have some mechanism to reach them. Now the question is your tech or your system flexible enough to accommodate that mechanism or not, right? Because they're not completely sort of rural.
But you need to understand this is a journey. So you can start taking consent. That doesn't mean that in day zero, everybody in every system is providing you with consent, or to say you're successful. You can say, okay, fine, I will reach 100% in 10 years or 5 years. So what happens is you keep learning. Because I know when we are talking about consent, a lot of blank faces, because you're thinking of a lot of different scenarios with hardcore core like that. The main concept is you need consent because this is somebody else's personal healthcare data. Now, how you implement it, how you measure it to a certain level where everybody gets included in the consent mechanism, keeping that perspective in mind is important in your journey. Just because it might not sound possible right at the moment you throw it out of the table, well, I don't need it. We should not do that. We should keep it there always to remind us that, yes, we need consent. And then try to push yourself along the journey to make it more mature and slowly, gradually increase the, I would say, reach of the consent mechanism.
Super. Oh, there's one last one. Okay, sure. Last one, and then we'll close it.
Hi, I'm Musa. I'm from Dynamic Solution Innovators, and we are working on the SHR project with A2I and DGHS. So my question, I think it relates more to the previous session actually. It's that incentivizing providers and facilities to get on board would require establishing a claim exchange and making claim applications easier. But in context of Bangladesh, where the market penetration of private sector insurance companies are not that significant, how can we address that? How can we incentivize providers and facilities to get on board? Thanks.
Yeah, no, good question. And this is why, to the earlier point, the use case has to be very carefully, the adoption use case has to be very carefully tailored per country. So one starting point is that the penetration of insurance might be low, in part because claims is an issue. And so instituting claims infrastructure by itself is probably a mechanism to increase insurance penetration. But we can keep that aside. I think your core question is around adoption of data sharing, let's say, right? So and this is the main issue in any data sharing architecture that's a network is always, why should anyone adopt? It's not even on the technicality of what data, what module, etc. So I think because everyone is worried about they're more worried about giving away their data than their money, I would say, in general, right? Because they're worried about what will you do with my data that I couldn't do with my data, and therefore I'm afraid of you, right? So I think in order to frame this, one way, I mean, we framed claims as an example, but claims is an example of an initiative or an exercise that is of deep value to that institution. So I think the only way to bring data sharing to life is to find a use case that that hospital cares deeply about. So I'll give you an example from, let's say that hospital has a insurance product that they have that they're trying to push, or they have some app that they're trying to push. They'll have some agenda, right, broadly, that they're trying to frame. I think first saying, look, you have to join a data sharing network in order to access data from another side or other parts of the ecosystem is the first step. To say, look, you should have reciprocity. If you actually want to access data from anyone that's not in your bubble, you need to join the network. It's a reciprocal network. If you provide whatever data you have, you surely don't have more data than the rest of the ecosystem combined. So the first framing is that of the collective data that's outside of you, being able to access that in real time, and framing that as a reciprocal ecosystem where you have to provide in order to access. So that, I think, is the first framing. The second is to say, okay, they have to pick sort of a use case where they will tremendously benefit from the data that they are able to access or share. Right? And so, okay, let's say you have a small practice, you are trying to grow your practice in neurosurgery, but you don't have any existing patients in neurosurgery, but you've hired 2 new surgeons, right? Now, how will they actually cater to the market? Maybe they'll bring in, maybe the patients that come in that already have, that get referred to you, that already have data in other places, they'll be able to share it with you. Now you can grow your neurosurgery practice. But I think framing that value proposition, it was our main point. I think for different entities, you might have a different value proposition, but the core is to identify something that they want and they already need to do, and framing data sharing as one critical building block in that broader agenda. I think, and this is the challenge of data sharing as infrastructure. The moment you're trying to create a public good, right, where it's like a registry and everyone is contributing and everyone can access, it's simpler in some sense to execute because everyone gets it. They're like, okay, I'll give 3-4 data fields about myself, but in that registry there will be data about everyone else and I'll reference it. So contributing to registries for some reason is not considered difficult, but the moment you have to invest in infrastructure that allows for real-time response to a data request, that's when they have to really make a business case for it. And for that, we just urge you to frame it in terms of their point of view, of their goals and what they want to do, and to frame data sharing as a crucial component of whatever goal they have, because it probably is, is the real framing. Yeah. Any other thoughts you want to come in?
No, it's okay. This was quite comprehensive enough. Yeah.
All right, super. I think this is a really helpful session. We've been working with A2I for the last, I would say, 11, 12 weeks, as well as with individuals from the Ministry of Health as well that have come in on these discussions to actually formulate what the right digital health DPI blueprint might look like for Bangladesh. So if any of you are keen to sort of contribute to that effort, maybe you can raise your hand, reach out to Mohammed as well in the back, and or me or anyone in this ecosystem. I think we'd be happy to take contributions and input. But thank you so much. Thank you.
Thank you all.